Elizabeth Yeowart-Montgomery. I'm also an optometrist and I work in the medical science team for Essilor Luxottica. Part of my role is liaising with academics and ophthalmologists. The rest of my role is training clinicians and creating educational content around the topic of myopia.
Hi there, my name's Garrey Haase and I'm an optometrist with two practices in North Yorkshire and East Yorkshire. I've been qualified for 24 years and more recently taken a special interest in myopia and its management. I've just recently completed the Glasgow University course on myopia and its management.
So myopia is a refractive condition of the eye, and what that means is it's how the eye focuses. Myopia is the technical name for short-sightedness, and that means that people who are short-sighted can't see as well in the distance as they can at near. So they will struggle, for example, to see the whiteboard at school, the television, or as adults with driving.
We know that the prevalence of short-sightedness has been increasing, and over the next 3 decades it's going to increase even more, so that 50% of the population are believed that they're going to be short-sighted. From a practical point of view and on the ground, we are seeing more and more children coming in that are short-sighted, and starting to treat them at an early stage is really important. So getting them in very early and having an eye examination from an early age is really important so that we can then deal with this.
Yeah, it's interesting, isn't it? You know, we're seeing children at a much younger age, aren't we, coming in who are short-sighted?
We are, yes.
And, you know, when I was at school, which is a very long time ago, not many children at primary school were actually short-sighted. It was more puberty, wasn't it? Early teens, whereas now we're very much seeing them really ages 6 to 10, so we're really seeing a shift in when the myopia becomes apparent in these children.
We are, and the other thing that I'm finding is that parents are more aware of it, but also they're more aware of the fact that we may have to start dealing with short-sightedness and giving them glasses at a younger age and before they become too short-sighted.
Exactly.
Whereas previously we would maybe leave somebody who was very slightly short-sighted, we may say, well, they're okay, maybe they might need them next time. Whereas now we're actually talking about giving them glasses.
That is really true, and I know in your introduction you said you've been qualified more than 20 years. I'm nearly 30 years, and certainly when I was newly qualified, we were told to undercorrect a myope, to leave them, weren't we? And I look back and I think these poor children still couldn't see the blackboard as it would have been because we didn't actually intervene. So the whole teaching around it and the evidence base has changed, hasn't it?
Absolutely, and of course now we're saying we need to make sure we fully correct them, because otherwise they're going to change even quicker.
Exactly.
And of course this is what's brought on myopia management, is how do we correct them and all the things that we've learned.
Yeah, absolutely.
So the next thing is, as a parent, should I be worried about myopia? And I don't think they should be worried. Although we're now terming it as a disease and we're talking about treatment as opposed to just correction, as a parent I think it's something we should be aware of. I think it's something that we need to make sure that we are getting our children into the opticians from an early age and being aware that we can now treat myopia and help to reduce the rate of change. So it's not something that we need to be afraid of or cautious of. I think it's something we need to embrace. Don't know what you think, Lizzie.
I agree 100%. You know, don't be fearful of it. Don't worry unduly. You know, Garrey and I are both parents. We know we've got enough to worry about as parents, but be vigilant, be mindful. Be informed of the potential signs and symptoms of myopia. So is your child screwing their eyes up? Are they having to move closer to the television? Are they spotting things in the car later than their siblings or you are? And are you short-sighted, or are their grandparents short-sighted? Just have it in your mind. And as Garrey said, I think it's vitally important, isn't it, to have regular eye examinations, even if you don't think there's a problem. And I think we're very good at taking our children to the dentist, aren't we, for a checkup in the absence of any problems. And actually we forget that we really should be taking them to the optometrist as well as a start and for a routine eye exam.
Absolutely, and it's something that's always been a bugbear of mine, because if you look at the red books, we all get a red book when we have a child, and hearing checks and dentistry are highlighted in the red book, and there's a very, very small line right at the back of the Red Book that says, don't forget to get their eyes tested.
Yes.
Now, as a practitioner who sees children on a regular basis, I'm very happy to see, I say normal, children who don't have a problem, I'm very happy to see them from the age of 3.
Yes.
If you think you've got a problem with your child, I will see them at any age. And I've done babies that are 6 weeks old.
Yes.
So there is no minimum age for a practitioner to see a child. And the sooner they get in, the better, because then they get used to dealing with us like the dentist,
Yes.
like their hearing checks. So it is in the Red Book, but it's a tiny little line. But I think we need to make more about it.
Yeah, you're absolutely right. And when we think the impact that myopia has on a child,
Yeah.
as one would imagine, it will affect the learning. You know, if a child can't see the whiteboard, academically they can fall behind. But also that social side, isn't it? You know, again, as parents, we both know that mothers in particular, I think, will have a look to their children, you know, to a behave yourself look. And if the child can't see it, they're not picking up on those facial cues. And I think that's the same with teachers as well, isn't it? You know, if a child can't see the teacher or the teacher's expression, they can really fall behind socially and lose confidence as well. So, you know, I agree with Garrey. We'll get them in as young as possible. I certainly saw children from a very young age. We can do a surprising amount, can't we? Without the child needing to, you know, reply to any questions. We can see an awful lot. There's a lot of what we call objective tests. And we can get a really big picture, can't we, just from those first few minutes with a child.
That sort of answers the next question which we get asked, which is, if we don't correct the short-sightedness, what's the impact? And you've already covered it, that obviously 80% of our learning is through our eyes, and the social impact. So there's two different things. One is correcting the short-sightedness, which we can do, and if we can do very easily. The second thing is treating the short-sightedness, which is a slightly different topic. But in the first instance, we should always correct the short-sightedness, and we should correct it to its fullest.
Yes.
So that then it doesn't change as much, and the rate of change will slow down, even if you're just wearing the glasses when you should. And the research shows that. So correcting it is important in the first instance, but then we can go on to treating it, which then talks about what's available in that respect.
Yeah, absolutely.
So part of our discussion is some of the risk factors. Some are modifiable and some are non-modifiable. The two that we can't do anything about are our ethnicity, and people of a Eastern Asian background are more at risk of short-sightedness. The second thing is genetics, and if you've got one parent who is short-sighted, you're more at risk. If you've got two parents who are short-sighted, then that increases the risk even more, and there's a very good chance that their children will be short-sighted as well. So those are the two that we can't modify. There are, however, two that we can influence. Lizzie?
That's right, yeah. So the modifiable risk factors are behavioural, really, and that is outdoor time. And research has shown that the more outdoor time a child has, the better. That seems to slow the progression of myopia, of short-sightedness. And the International Myopia Institute do recommend that a child has a cumulative time of 2 hours per day outdoors. The other risk factor is, probably not surprisingly, the amount of near work. Not necessarily digital devices actually, but any form of near work, and that is shown to increase the progression of myopia. So really the first line of advice we should be giving to all parents and all families is increase outdoor time for the children and reduce the amount of additional near work that they need to do after school. Again, as a parent, I know that's easier said than done, but the best thing is if they can't come off the devices, and again, we don't want to make enemies of these children, we can recommend that they break it down into 30-minute segments rather than sitting for 2 or 3 hours at a time on a near visual task.
The other thing that I learned, which I learned when I did the course, was that the distance at which they do the near vision.
Yes.
So if they hold it too close, and this is perhaps one of the disadvantages of devices, and I know it, as you've already said, it's not just devices. We don't want to make an enemy of the device either, because it's part of our world. But if they hold a phone, we usually hold it quite close. Whereas if they hold the phone further away, then that also helps reduce the risk. And so learning and teaching the children to hold their phones and devices further away. And I know some of the modern phones are now saying they've got an alarm on you can set where it says device too close. But that goes for writing and drawing and sewing and all those near work activities.
Yeah.
Hold it further away.
Absolutely, absolutely. And we've all seen, haven't we, children in a pushchair, you know, holding a tablet or a phone really close to them. And you think, oh my gosh. But yeah, absolutely, that's a perfect point. Yeah, we need to hold things a little bit further away.
Yeah. So one of the things that I found interesting is why all of a sudden have we started to make a big issue of short-sightedness? And it's always been there. Okay, it's not been as prevalent as it is, but maybe that's because our lives have changed and our lifestyle have changed. But why all of a sudden are we making a big fuss about it? And the really interesting thing is that we are now calling it a disease. It's being termed by the academics as short-sightedness is a disease, and it's diseases we can treat. But 80% of short-sightedness is caused by the eye being bigger. We call it axial length, and it's longer. And there is a consequence to that, albeit very small, but there is a consequence. And being the medical science expert, I'm going to let Lizzie explain because she puts it into such beautiful terms.
Very much. Yeah, I mean, as Garrey said, 80% of myopes, so 80% of people with myopia, approximately, are that way because the eyeball's actually too long. It's almost too strong, so the front to back length of the eyeball is too long. Now, you've probably all heard of the retina, and that is the light sensitive part of the eye. It lines the inside of the eye. And as you can imagine, if the eye is bigger, if it gets longer, that gets stretched. And I always say it's a little bit like a pizza dough. If you're stretching dough too thinly, ultimately it will break, it will tear, it will get damaged. And that is what happens with the myopic eye. And that therefore in later years can lead to consequences. So it can put that person at slightly increased risk, so a relative increase of disease compared to somebody who's not short-sighted. So things like a retinal detachment, again, many of you will have heard of that. That happens when the retina gets too thin and it breaks or it tears or pulls away. And that is one of the most common diseases that we do see in short-sighted eyes. So it's really important that we try and mitigate that disease. That's our role, is try and mitigate the disease, to try and control the myopia, slow the progression down, to therefore ultimately reduce the risk of those diseases associated with having a short-sighted eye.
We've used a couple of terms which I think we need to explain a lot more, Lizzie. We've used the term correcting short-sightedness. And correcting short-sightedness is something that we've been doing for probably centuries now. There are signs that glasses were in the Roman times. So correcting it is just where we're actually enabling the patient to see by making the image focus on the back of the eye. So it's focusing on the retina. But actually we've used the term treating myopia. And treating myopia is where we're going to slow down the rate of change. And there's been lots of research, and these forms of correction and these forms of treatment have come to the fore in the last 10 years. And now a lot of practices are offering glasses or contact lenses that treat myopia. And I think if we can expand on that a little bit, because that's really important that parents understand what the difference is between correcting myopia and treating myopia.
Yeah, absolutely. So, it has been centuries, hasn't it? We've been correcting eyesight for. So, any parents that are short-sighted, they're probably aware that they have a minus prescription. So, if you wear contact lenses or glasses, it'll be a minus number, -1, -2, and so on. And that, as Garrey said, corrects the short sight, so it enables the child or the adult to see what they need to see. Myopia management, myopia control are interchangeable words, and these are treatments. And what our aim to do with this is to actually slow down the rate of progression, because that's been the biggest change, hasn't it, over the recent decades. And it's interesting, it has been decades. You know, it was back in I think it was the late 50s, the very first research was done on myopia management, and clearly somebody there was concerned about how much myopia is increasing in the population. And there's been a whole raft of research done. It's a very rapidly evolving field. But there are now treatments available to slow down that rate of change, and that is the vital difference. So we call that myopia management or myopia control or treatment, and that is different to the normal minus spectacle lens or the minus contact lenses that you have to actually enable you to see more clearly.
And there's different forms of treatment. So there's within the United Kingdom, there's three main forms of treatment. The first is spectacles, so special lenses incorporated into a pair of spectacles. The second is contact lenses, and then the third is what is termed as night lenses, or its real name is orthokeratology. That's a little bit more specialised, but it's where you wear lenses overnight whilst you're asleep. And those are the three main forms of treatment. The first two, most practitioners and most practices will offer that. The orthokeratology is a little bit more specialised, and because you go round, you'll probably see, I don't know what the percentage is, but it will be quite small, the percentage of practices that do offer orthokeratology.
Yeah, I don't actually know the percentage of practices that would offer orthokeratology, but certainly the vast majority of optometric practices now will offer a spectacle myopia management option and a soft contact lens myopia management option as well. So there is always something to suit that child and that child's needs.
So one of the questions that I get asked an awful lot in practice is, what's the difference between the myopia management or treatment lenses to a normal lens, and what makes them different, and why do they work, and how do they work? And obviously you've got to, working with Essilor and working with those lenses on a daily basis, you've got a really good understanding of how they work. And whilst I've got a good understanding, it's not as technical as yours.
You're very kind, Garry, thank you. Yeah, I mean, I work for Essilor, and the Essilor myopia management lens is called the Stellest lens. And years of research and development have gone into the design of the Stellest and of the other specific myopia management lenses and contact lenses as well. And really what they do, they slow down the signal from the brain that tells the eye to elongate. So if we remember that the majority of short-sightedness is because the eye is too long, the front to back length is too long, and the reason it grows excessively is because the brain is telling the eye to get longer. And what these specific myopia management spectacle lenses and contact lenses do is they slow down that signal by just causing a little area of what we call defocus on the retina. We don't need to get into it too much, but do know that they work very, very well indeed. There's very robust data supporting these designs, and they have what we call good efficacy, which is a good outcome. It slows down the axial length in millimetres, so it slows down that length in millimetres, but it also slows down the change in steps of power, so the diopters. We measure spectacle prescriptions in diopters, so it slows down the rate of change in diopters as well.
So you've mentioned a couple of interesting things there. We've talked about the length, and you've talked about the elongation of the eye, but then you've also talked about diopters. Now, diopters is, as you say, it's the unit of measure that we tell what the prescription is. And one of the other things that we find is, how do we know these lenses are being successful? Because surely if we're just being able to tell what the prescription is and saying, well, that prescription's not changed, therefore the lenses must be working. But then we also get some children, and we know that children like it as strong as they can get because it makes it smaller and blacker, and they like that contrast. And I remember back when I was at university, all those years ago, that they told us to give them as little minus as we could get away with. So give them as much plus. But children like it short-sighted, so they're going to add extra short-sightedness. They're going to want that. So how do we know that the lenses are working? And I know what we do in our practice, but before we go on to that, from the expert, let's hear.
Yeah, very good question, isn't it? So we will always know whether a rate of change is slowing down. So has that child's prescription changed by fewer steps of power in this period of time compared to the previous period of time? And there is a link between the diopters and the axial length, which we measure in millimetres. But that link isn't always absolutely 100%. So some myopia management treatments, for example, will change the diopters, but they don't necessarily work on the axial length. So because of that, measuring axial length is a gold standard. That is the only way we absolutely truly know whether a myopia management option is working. And it's also what we're most concerned about because of that disease risk. Mm-hmm. And as we said, the longer the eye gets, so the greater the axial length, the greater the chances that child will get a disease in adulthood, or a change in the eye structure that may lead to a disease of the eye. So that is the gold standard, and it's really important. And I think, to your point, you're absolutely right. Children like to have as much minus as possible, and the only way to be absolutely 100% certain and to be absolutely repeatable is to measure the axial length, and we do that with an instrument called a biometer.
Yeah, so as I said to you, I can tell you we've got biometers in our 2 practices, and when I did the course through Glasgow, what they were emphasising was that the biometer is the true gold standard. It's what the College of Optometrists recommend as the gold standard. And if you don't have a biometer, then doing what we call a cyclopedic autorefraction. The point about these machines is it takes away any influence from the patient or the practitioner. So it can be done by anybody and it can be repeatable. And what we've found, and a great anecdote, is that I had a patient who was on the treatment. We did a normal eye examination for her, and she wanted an extra 0.75 stronger in her lenses. And then what we did was we did the biometry, and when I did the biometry it hadn't changed, and that rang the alarm bells for me. So I then did a cyclopedic autorefraction, which is basically stopping her eye focusing and measuring the power of her eye, and I found that on that it hadn't changed. And when we went back to it and did it again, she was seeing just as well with the existing prescription. And so by using the 3 combinations, it gave me the confidence to know that these are working. And the measurement of the eye, the biometry, is really, really important, because I think that that's what tells the parents is something, a tangible measurement that they can see, and they can see that it is easily repeatable. And so therefore it doesn't matter what time of day you do it, it doesn't matter how tired the child is, it doesn't matter how grumpy I am. It works, and it works really well, and it's very repeatable. And that's what we're now saying is the gold standard.
That's right. It's a non-negotiable measurement, isn't it? You know, I could do it, you could do it.
Yeah.
As you say, we could do it at any time of day. And it also measures to 0.01 millimetres, which is very, very sensitive. And just, again, an alignment between the diopters and the millimetres. We tend to measure spectacle prescription or contact lens prescription in steps of 0.25 diopters, sometimes 0.12, but generally most practitioners would measure it 0.25. Now, 0.25 diopters is very, very similar to 0.1 millimetres, so those are the equivalent values there. So 0.1 millimetres in axial length equates to 0.25 diopters in prescription. But we can measure the axial length to 0.01, so it's 10 times more sensitive, and therefore we can really, really pick up any changes if there are any, or perhaps most importantly, as Garrey said, when there aren't any changes, actually,
Absolutely.
Which is what we're wanting, isn't it?
And that just gives the parents the confidence to know that the treatment is working, that they're investing in this, they're investing in their child, and that the treatment is working. But we also have to remember that all the research with all the treatments say that it reduces the rate of change, it doesn't stop it. And there was a great term that came out around 5-6 years ago, which was every diopter matters. So in some children, you will still get quicker rates of change than in others, but of course what we don't know is if they weren't on the treatment plan, how much more would they change? So even though it is changing, it's changing in most cases at a slower rate, and that's really important to remember and to make sure that we've got that in mind, that it is still working.
Absolutely. And it's interesting you say every diopter matters. I use that in every single presentation I give. It was Professor Mark Bullymore who did a lovely meta-analysis of looking at data and disease. and mitigating disease, and found that really saving a diopter, so instead of a child's prescription, say, getting to a -3, if we as optometrists can keep them to a -2, that can reduce the risk of future disease by about 20%. It's really, really significant. And it doesn't matter where on the scale it is, whether that's between a -1 to a -2 or a -10 to a -11, that diopter still matters. And to your point, Garry, about the eye still needs to grow. You know, a child's eye isn't a fully developed adult eye. It still needs to grow at a normal rate. And that's what we want to do. We want to slow the rate to that of a normal growth pattern, rather than that almost exponential growth pattern that we do sometimes see in myopia. So it's absolutely normal for the child to still grow. We'll see a normal increase in axial length, but we don't want an exponential increase, and that's where we can be really specific and sensitive with the actual length measurements.
One of the great things that has happened in recent times is the increase in products that are available and the huge range of products that are available to us. So as a high street practice, I've got now several different spectacle lenses from different manufacturers, and they all work very slightly differently, and they will correct the astigmatism as well. Until recently, contact lenses was always a little bit of an issue. So there were two main different types of lenses that work differently, but they never corrected the astigmatism. But now we've got a lens that does, and the research that's out there is really good. It shows that it does work, and it works really well. So it's giving us a good range of different products. But maybe, is there too many for a high street practitioner? And how do I decide which is the best lens for me, for my business, but more importantly for my patient?
Yeah, it's a very good question, isn't it? And you're absolutely right. You know, even the past 12 to 18 months, there's been so many new, particularly spectacle lenses come to market, all of which have got efficacy. So that means they all work, but they work to a greater or lesser extent. And I think it's really important that a clinician, so the optometrist, is able to say to a parent, well, this is priced at this other option is priced at this. The difference in the price is because one has got more research and development behind it, it's got more longitudinal data, which means there's more years of study behind it, and it's a more technical lens. It's been designed specifically for myopia management. Some of the newer lenses on the market have certainly got lower efficacy. They're better than nothing, without doubt they're better than nothing. But I do think it's important that if you are offered an option for your child, that you are informed in the decision that you make, and you make the right decision depending on your budget, depending on the prescription of the child, the age of the child, and what the clinician can advise you. So it's very much, the ultimate goal really is for the child to be compliant with wearing whatever option they go for. So it's dose dependent. So the longer a child wears a spectacle lens or the contact lens, the better the outcome, the better the efficacy. So first of all, the child needs to be comfortable. They need to want to wear it or be happy to wear whatever option they choose. But it is really important that clinicians alike, parents, do understand the differences between them and the efficacy, the research, the clinical trials, and actually what makes a good clinical trial. You know, it's very easy, isn't it, to look at a glossy brochure or a spectacle lens website, but actually it's really worth doing a little bit more due diligence and looking really into the sort of the deep dive into that randomised controls trial. Is it at least 2 years of data behind it? Is it a wider age range? All these factors make a difference.
So as a parent, I'm going to be influenced by the optician, the optometrist, because I'm going to them as the expert. How do I know that they're not just selling us the best lens for them and their business without, where do I find this research? Where do I find the answers? Because you're saying that I need to do some research as a parent now, putting my hat on of parent of 4 children. How do I know where to find that? And how do I know where the research is? And not just being influenced by the optometrists who's selling the best lens for their business.
Yeah, it's a very good question, isn't it? There's a very good website called myopiaprofile.com, which is an impartial website that has got information about every option available. You can find it there. It's very parent friendly, it's very child friendly as well, actually. But you can always ask the optometrist as well, you know, ask them what lens is it, what's the efficacy, what's the research behind it. Don't be shy. This is a medical intervention, and certainly as a mother, if somebody recommended a prescription medication for my child, I would want to know what it is and why. So don't be afraid to ask the optometrist, and the optometrist should be able to tell you the brand name of the lens, the technology that goes into that lens, and at least some degree of efficacy. They should know something about the efficacy. And if you're offered a choice of options and they may be at very different price points, ask why. You know, you need to know what you're paying for and what the difference is, and that way you can make the informed choice that's right for your child.
So you would expect the optometrist to know how a lens works and why, if they're selling two different lenses, what the difference between those lenses is. That's not an unreasonable expectation.
I don't think it's unreasonable at all, no. There will always be some optometrists that have got a greater interest, like yourself. You've got a real passionate about myopia management, so you'll be very, very well informed. But it is part of the remit now. We would be remiss not to recommend myopia management when appropriate. That is in the professional guidance now. So yeah, I do think an optometrist should know what they're recommending and why, particularly because it is a medical treatment and because it's for a young person.
And so you've just mentioned something else which actually I didn't think about, but I do remember, and I've heard it, that it's in our professional guidance now that we have a responsibility and a duty to mention myopia management with all children that we feel are at risk. So how do you go about if you've got a child who's short-sighted but you don't offer myopia management, are we expecting that optometrist still to mention it and recommend somebody else?
That's exactly it. Yeah, so it is very, very important that we do recommend myopia management when it's clinically appropriate, or when that child has been identified at being either at risk of myopia or is indeed already myopic. And it's absolutely fine if a practitioner doesn't wish to offer myopia management solutions. That is absolutely fine, but it would be the best in their professional interest to make that recommendation, and then to point the parent to a practice or a clinician that does offer myopia management. That's absolutely fine to do so.
Okay, and do you know, is there a central website that lists all the practices that offer myopia management?
Not to my knowledge. It would be very useful if there was, wouldn't there? But, you know, my recommendation would be, if you're a practitioner, put it on your website, put it on your social media, and that way at least people, if they're doing an online search for an optician that does myopia management, you'll come up, you know, put a sticker in your window, make it easy for that parent to find you.
But I'm sure the manufacturers, if you look them up, they would have a list of who sells their lens.
They do, that is a good point, they do, but it doesn't necessarily show that their optometrists are, you know, as passionate as you are about it.
Yes, that's a different, there's different levels, isn't there?
That's correct.
And there is different levels, and I know there are more opticians doing the course that I've done.
Yes.
And it is growing. There's also, interestingly, other, not just optometrists doing it. When I was doing it, there were a couple of dispensing opticians, but also some nurses doing it.
Yes,
And I assume they're working in hospitals and things.
That's right.
And there were also some overseas students that were doing it. So it wasn't just, but there was only about 30 of us. So it's quite a small cohort when you consider the size of the country and the number of different people.
Yeah, exactly.
In my practice, I do myopia management. I start as young as the patient needs. So as soon as I find that they're short-sighted, I recommend and I talk to the parents about myopia management. And that can be a 4-year-old, or it could be an 8-year-old, or it could be a 12-year-old. It doesn't matter. I get asked all the time, when should they stop? And of course the answer I give is, well, when we think that the eye has stopped growing, when we think that the myopia has stopped progressing. And again, we always used to sort of use somewhere around 18, 20 years of age. And what I've always said to parents is, when we feel that the time is right, we can take them out of the myopia management, put them into normal standard lenses. We'll then see them again 6 to 12 months later, no more, and see, has it progressed? And if it has progressed, we can put them back into the myopia management because we know it's not stopped. Is there a recommended age? Is there anything that research shows that says you should stop at this point?
No, there isn't. Most of the clinical trials are for children aged between about 6 to 19. That's where we've got robust clinical data. But as we know from being in practice, you know, we see many people in the 20s, don't we, that are still having progressive myopia. So my advice would be exactly what you said. We'll wait until that myopia has fully stabilised. We know that for certain when the axial length is stabilised. But actually, there's a very good study called the COMET study, and that does show that about 10% of 21-year-olds are still progressing, so are still growing. So we would generally expect at least 10% of our 21-year-olds to still be changing. And I think it's really important that you do have that conversation with them, that there is no finite end date on it. The good news is whatever myopia we've managed to save is in the bank. You know, we don't get rebound, certainly with the very good spectacle lenses and contact lenses. It won't rebound back to what it would have been without the treatment. But if that young person is still going to progress, they will still progress, and that's the thing. But interestingly, there's a couple of universities, I know for sure that Bradford University and Ulster University are doing ongoing research into that slightly older cohort, so 20 to 40-year-olds in the case of Ulster, which shows, doesn't it, that there's definitely those insights into that slightly older cohort that is still progressing.
That leads me nicely into my next question, which was, I found, and again, you go back to when you were at university and you remember the things you were taught, which was short-sightedness can start at any age and usually slows down or stops around 20. And then we get a stable period for 20 odd years, and then we get into what we call presbyopia or older eyes, where our near vision starts to go. I found in practice, in reality, I found an awful lot of people, patients between 30 and 45, who have suddenly become short-sighted. And that goes against all the research that we used to know. Now, we can look as to why, and is it digital devices or devices, is it short? But more importantly is there anything to stop us putting those people into myopia management lenses and saying, you might progress, and this might help you slow down? We know that their eye's not going to grow particularly, but is there anything stopping us?
No, there isn't. There isn't anything stopping us, and it's one of those things, isn't it? We won't know until we try, and I think that's the interesting thing, that there are no known detrimental side effects of having a myopia management solution compared to a single vision correction. And the good thing is, with that age group, you can have that informed discussion with that patient. It's different,
Yes,
isn't it, when
it
they can
is.
make their own decisions. But it'd be very, very interesting to see what research comes out of these newer studies with that older cohort. Really interesting to see. And I agree, I think we can almost throw the rule book away, can't we, with that sort of onset of presbyopia and that perceived sort of stability of prescription between maybe age 20 and age 40. We're not really seeing that anymore, are we?
Not at all. And that's the point, is that in the real world, not in the research clinical environment of a university, we are definitely seeing that, and there is definitely a much bigger percentage of people developing short-sightedness outside of the norm.
Yes.
So what is norm?
Yeah, exactly. The boundaries have changed, I think, haven't they?
Absolutely. Sadly, we've come to the end of this discussion, which hopefully you've enjoyed as much as I have, Lizzie. Firstly, I'd just like to say a huge thank you to you, Lizzie, for your expert advice and for sitting and chatting to me. I've had a wonderful time. I'd like to thank OptiSocial and Meg for facilitating this chat and for doing a fantastic job. And I'd like to thank Senhard in Knaresborough for hosting us and giving us the wonderful facilities. I'd just like to finish off that as a practitioner who sees these patients, the things I would like to highlight is, first of all, be aware of short-sightedness. Don't be afraid of it. make sure that you get your child's eyes examined from at least the age of 3, but even younger if you are slightly concerned. And make sure you do that on a regular basis, because even though at 3 they may not have any eye problems, they may have perfect eyesight, it can change. And then finally, don't be afraid of the cost, because at the end of the day this is a treatment plan that takes a long time to make sure it works. So invest in your child and have that good conversation with the optometrist, and make sure that you are fully informed of what's available.
Well, thank you, Garrey, for having me. As you know, I could chat with you all day about myopia management, indeed about anything. It's been a pleasure and a privilege, so thank you. So my final advice, I think, as both as a parent as an optometrist, is get your child outdoors as much as possible, so minimum of 2 hours a day. That is the International Myopia Institute's first line of advice. And do your research. Don't be afraid to ask or to challenge your optometrist. Really don't be afraid. You're investing in your child's future, as Garrey said. It's vitally important. So please don't be afraid to ask questions. Challenge your optometrist, pick their brains, and find out as much as you can about it.
Thank you, Lizzie.
Thank you.